very happy to be here, and I want to thank the IWMF and WM UK for organizing this, because I know very well from my own patients how important it can be to have a patient federation for education, of course, but also just to know, especially when you get this diagnosis that no one probably in your area or in your family will have, that it's good to find out that you're not alone. And I've seen in my patients that this can be a lot of support. So I'm very grateful to all the volunteers, and organizing this is a really good idea, and therefore I'm happy to contribute. And I know that a lot of people here, some of you will already know more about the disease, maybe even than I do, because some of the patients have become little professors in Waldenstrom. Other patients may be new, and they may not know so much. So my presentation will be a little bit for everyone, and just take out of it whatever you think is interesting. So these are the assignments that I got from the organization, and in the beginning I was given 7 minutes for this. I said, okay, if I say Waldenstrom macroglobulinemia really slowly, that already takes me 1 minute, so I'm happy I have a bit more time. So I will talk a little bit, and this is also overlapping with Dima's presentation. I will talk a little bit about classification, just to make sure we all use the same words for the same thing, about who is affected by WM, risk factors and mutations. And let's just start with a bit of history. I think most of you know that this disease has this complicated name because of Jan Waldenstrom, who discovered it in 1944. And I always say Stephen Trehan is the next Mr. Waldenstrom, because he made a very important discovery in 2012 about the MYD88 mutation, and he was also the one to do the clinical trial that led to the first registration of a drug, especially for Waldenstrom. So I think, yeah, he is another person who made really big contributions to putting this disease on the map and to making us where we are now. So I have some interactive questions, so let's see how it works. This is not about being right or wrong, it's just about to get you thinking about what I want to explain. So what is actually the difference between having Waldenstrom and IgM-MGUS? Is it whether you have symptoms or not? Is it your IgM level? Is it the number of tumor cells in the bone marrow? Or is it whether you need treatment or not? So I think people can still vote, or should I go back for that? Back? Still voting? Okay. So this is interesting, huh? So there's lots of different opinions. And actually, I'm happy there are, because I think the distinction between IgM-MGUS and Waldenstrom is on the one hand important, on the other hand it's very artificial, because the actual definition of WM versus IgM-MGUS, well, I will not go into it. There are actually two definitions, but I will discuss one of them. The definition is made by the number of cells in the bone marrow and a bit by the IgM level, but the major distinction is whether you have less than 10% malignant cells or more than 10%. And this is, of course, a very artificial number, because there is no biological difference between 9% and 11%. It might just be which part of the bone marrow you puncture, you know. So it is a sliding scale. And for the cause of research and clinical trials and prognostication, it's good that we have this definition, but it's not like a hard line. So this is good to realize, and I think that's reflected by all the answers you gave, so very well. What is interesting about Waldenstrom, and one of the reasons that this disease is so heterogeneous and that every patient can be different, is that what makes it different from other lymphomas is that you do not only get sick from the tumor cells themselves, but the IgM protein that is circulating in the blood can have lots of different actions in the body, and it can affect via all different routes that I will not discuss now, but it can act in many ways, and it can have different properties in each patient. So that means why some patients will have no symptoms at all, other patients have very low tumor cells, very low IgM, but they still have a lot of neuropathy complaints, or they might have hemolysis because of cold agglutinin. So every patient can be very different, and this is what, as a researcher, also makes it very fascinating, but also very challenging as a doctor to direct the right approach to each case. Having said that, there are a couple of things that we can say about all Waldenstrom patients. So this is a disease that does not occur in children or young adults. Average age is 65. The youngest patient I know is 29, but that's really an exception. And the yearly incidence it's a rare disease, so 10 to 20 in every million for a new diagnosis every year. So this means in our country, where we have 17 million inhabitants, that we have about 340 new Waldenstrom patients every year. We know this from the National Cancer Registry. Fortunately, people with Waldenstrom live many years, typically with this disease. So it means that the people living with Waldenstrom in the Netherlands is a much higher number, about 1,500 or maybe even 2,000 people at this day today. So IgM-MCAS is a different story. MCAS is very common in elderly people, and this might be a much higher number. We don't know exactly because it's not in the cancer registries, but MCAS is much more common. And the good news, of course, is that the majority of MCAS patients never gets into trouble and just have this condition with them until the end of their lives and never have any symptoms or other complications from it. The transition from MCAS to malignancy, it's very rare. So only from all MCAS patients, only 1.5% every year will move into the Waldenstrom category, which does not mean that they will need treatment. So they might then go into watch and wait for Waldenstrom. So MCAS has a much better lookout, of course, than Waldenstrom because it's a different stage of the disease. So I found this interesting, quite recent publication about how incidence of Waldenstrom is not equal in everyone, and this is based on people's backgrounds. And what you see here is that the majority of Waldenstrom seems to occur in people with a white background, and all the other backgrounds have much lower incidences. And this is indeed what I see also in the clinic. There is, of course, the reflection of the whole population, but it's definitely not equal in every group. So this I thought was interesting. This is a very big publication from the United States. Also, it's much more common in males than in females. So I was asked to talk about risk factors for WM, and the good thing is we don't know a lot of risk factors, so it's not associated with smoking or alcohol. It might be related to chronic infections or autoimmune disorders, but we're not even quite sure. And this leads us to genetics. So Dima mentioned this a bit, but I'm going to explain a bit further. This is something that you really have to think about, because genetics does not necessarily mean hereditary. So we have on the left-hand side, which is what we have in Waldenstrom, what we call somatic mutations. And somatic mutations only occur in the tumor cells. So by definition, you cannot pass them on to your children because they are not in all the other cells in your body. You were not born with them. This mutation only occurs in that cell that has gone wrong in the bone marrow. So that you will not, for example, if you would take a skin biopsy, you would not find it there. So this is the situation for the mutations that we find in WM, like MYD88. On the right side is germline mutations that you are born with and that you can pass on to your children. So there is a lot of research also in Waldenstrom on these things, because Waldenstrom, in a very small subset of patients, it can have a familiar pattern. So there are families where 3 brothers have Waldenstrom, their father has it, and their uncle. So clearly there is something going on, but we have not the answer to that yet. So there is not this one mutation that we say, okay, that means you have hereditary Waldenstrom. It has not been fully elucidated. So we don't know a lot of detail on this yet. So what I'm going to, this is what I said. There is familiar clustering in some patients, but it's only a small subset. In most patients, it's just you're the only one in the family. And there is no genetic test for that. And the problem with it is probably not just one gene that makes it heritable. It's probably very complex, and that's why we haven't discovered. So in Waldenstrom, so I'm now going to talk about mutations in the tumor cell that you cannot pass on. What is the most common mutation? Is it a combination of MYD88 and CXCR4? I see I made a mistake in this question. So, yeah, because the first 2 answers are the same, so well, that's the way it is. So is it a combination of MYD88 and CXCR4? Is it the ARID1A mutation, or is it the MYD88 mutation? So I'll let you think about this for a moment. So you can choose A or B, and it's the same answer, so that's fine. So there are basically 3 options. You're good. So I don't need to talk about this. It's true. So the MYD88 mutation is very common. We think if we use very sensitive tests, then probably 95% of Waldenstrom patients and MCAS patients have this mutation in their tumor cells. The CXCR4 mutation joins that in about 40% of people. So 40% of Waldenstrom people will have the 2 mutations. The other 60% will have only the MYD88. ARID1A mutation is the next common mutation, but it's less frequent. So I think it's about 15% or something, and we don't know very much about this mutation in terms of its meaning, and we don't routinely test for it. Yeah, of course, you've all heard about the MYD88 mutation. I think in most patients it will be tested as well. That's what we recommend in our national guideline, because it's really good to, if patients don't have this mutation, then you should really scratch your head and think, is this really Waldenstrom, or should we look for another diagnosis? We do have MYD88 negative Waldenstrom, it does exist, but it's very rare. The CXCR4 mutations, so MYD88 mutations is just one mutation. It's very easy to test. Well, there are some exceptions, but usually it's very typical that one single point mutation, same mutation in every patient. CXCR4, on the other hand, is much more complex. There's lots of different mutations in different parts of the gene that can occur. So testing is much more complicated. And it's also more difficult to learn about this mutation because there are many of them. So when a patient is CXCR4 mutated, the other patient might have a different mutation, which may have different effects on the cell. So therefore, this is a bit more complex and for the laboratory also more difficult to test in an easy way. So it's used less frequently in the clinic. MYD88, on the other hand, is quite easy. So this is a slide from Dr. Buska and his colleagues, actually. It summarizes, so the most important clinical meaning of the MYD88 and CXCR4 mutations are in treatment with BTK inhibitors like ibrutinib. We know that ibrutinib is most effective in the majority of patients that only have the MYD88 mutation. It's a little bit less effective, but still very effective when you also have the CXCR4 mutation. It just takes longer for you to respond. And if you don't have the MYD88 mutation, it doesn't work very well. So this is a very important reason. So we usually recommend to test for mutations before you consider using a BTK inhibitor. For all the other treatments, we have not seen these effects yet. So individualized treatment is basically, especially in the setting of BTK inhibitors, I think it's important. What does MYD88 do? So why do the tumor cells have this mutation? It stimulates the NF-kappa B pathway, which is basically a growth factor for WM cells. So when you feed your plants with, I don't know what it's called in English, but you have this stuff that you can give to your plants to make them grow faster. NF-kappa B makes lymphoid cells grow faster. And what MYD88 does, it's sort of like a key that gets stuck into the lock at the top side of this slide, and it makes this pathway go on and on and on. So the growth factor is produced in a much higher level, which makes the cells, it makes it easier for the cells to grow. So it gives them a growth advantage, which is what cancer cells need to survive. So this is the reason that the MYD88 mutation helps the tumor cells to grow. CXCR4 is more complex. One of the important effects of CXCR4 is that it keeps the tumor cells in the bone marrow. So it has something to do with the trafficking of immune cells from the blood, from the bone marrow or the lymphoid tissues into the blood. But it also has other effects on proliferation and migration, on cell cycle. So it has a lot of diverse effects, also again more complicated. But we do know that the CXCR4 mutations make the WM cells more active. So this is also a growth advantage in the end. So these were the things I wanted to explain for today. I wanted to thank you all for coming here, and please join the PhD students for their poster also later today. And finally, I wanted to make use of this stage to announce Annemarie Becking, who is also here. She's in that corner. She is doing a project on patient preferences to learn about what patients find important about treatment. And we want to do this because so many new treatments for Waldenstrom already there and coming up, you're going to hear about it more later, that it's very important for us, but also for the pharmaceutical companies and for the decision maker at the government to understand what is it that people really want. What is it important for them to have fixed duration, to have something that goes to an IV, or do people prefer a pill? All these properties of treatment are something that we want to study with a very special method, and we need Waldenstrom patients to do this study. It's an online questionnaire, so it's not a lot of work, but there will be a flyer over there. So yeah, there's no questions now, but we will have the panel later, and that was all for today.